The problem is if you break something, nobody here is able to fix it. So after almost killing one of my mentors and professors, I'm thankful to be here. It's a privilege to be here, and that's a tough act to follow. My name is Dr. Simone, or Carmine, and I work at Michael Garron Hospital. And I'll be talking about pulmonary neuroendocrine tumors, which is a little bit of a different beast, and I'm not going to ask how many here are affected by this type of Oh, excellent. Thank you for volunteering. So, you'll probably notice that your journey is probably a little bit different than some of the patients that have neuroendocrine tumors below the diaphragm. So I'll try to highlight some of the things that I think are important to highlight. Most of this I've copied from people that are much smarter than I am and more capable, but the patients are real. These are all patients that I've had in the last 6 to 8 months, and I'll be similar to Dr. McGillivray, I'll be going through about 6 cases or 7 cases, I believe, very quickly, just to highlight different aspects of pulmonary neuroendocrine tumor management. From a surgical perspective, I do want to emphasize what was already discussed. Most of the diseases that we're going to be talking about in the chest are dealt with in a multidisciplinary way. So you'll see that there are multiple team members that are involved in the care, not only in the workup of these patients, but in the post-operative management. I'm going to talk a little bit about the cases that I'm going to be talking, just disclosures, none of them which are going to be relevant for today. Nobody really pays me for my opinion. The diagnosis, we're going to go over the workup of the surgical patient, and we're going to highlight some of the key features about surveillance. So pulmonary neuroendocrine tumors are really divided into two, mostly the low and moderate grade and then the high grade. And then when we talk about things like low grade or moderate grade, we're talking about typical or atypical carcinoid. I think one of the speakers this morning said it best, we don't call these rare anymore, they're uncommon, but I don't consider them rare. And when you look at patients that present with an abnormal chest x-ray that we think is a lung cancer, it's about 2% of those patients will wind up having, 2 to 5% will wind up having a pulmonary carcinoid. Or in small cell, non-small cell, does comprise about 10 to 15% of all lung cancers. So this is not rare. It's actually pretty common in lung nodules. And so usually the way we approach these is very differently in those two arms, the low to intermediate grade and the higher grade. And the prevalence is about, we always tell the residents 10 to 1, so it's about 10 to 1 when it comes to the high grade, to the low to moderate grade, favoring the high grade tumors. And then within those subcategories, once again, 10 to 1. So we see far more typical carcinoid than atypical carcinoid or mixed cell histology. And then for the small cell and the large cell neuroendocrine feature or neuroendocrine type cancers is again 10 to 1 favoring small cell lung cancer. So patients come usually with an abnormal chest x-ray, and the most common thing that we see is a lung nodule or a spot, and that's what maybe some of you have started your journey with is an abnormal chest x-ray. And so the way we approach a patient who has an abnormal chest x-ray, we usually get a CT scan, we try to get a biopsy. We don't tend to offer bronchoscopy for these patients because that's not really helpful in coming up with a diagnosis, and then we assess the patients to see how suitable they are to have surgery. And in this population of patients, those numbers that I quoted before apply. So about 1 to 2% have low grade to moderate grade neuroendocrine tumors, and about 10 to 15% will wind up having a small cell lung cancer. And we treat those very differently. But then there's another type of patient which comes. This is a 25-year-old patient that had acute exacerbation of her asthma while she was 24 weeks pregnant and came to the emergency department because she was coughing up a bit of blood. And her x-ray shows that she has a bit of collapse of her lung. Well, endobronchial tumors are very different. So she was pregnant, so we couldn't get a CT scan, so we just took her to the endoscopy suite, and she winds up having an endobronchial lesion, which means a tumor that's blocking some of her airway. This is almost always a carcinoid, usually typical or mixed cell histology tumor. And so these patients we treat a little differently. We always offer these patients a bronchoscopy. We always try to get a CT scan, but in this patient we couldn't. And we always try to do a bit of a different workup, and I'll explain why these patients are treated a little differently. So the one key thing is that when patients do present with this type of disease is you have to get very good tissue so that we can get accurate pathology. And a lot of times, and this has been said many times before, the Ki-67 score for us is extremely important because it tells us how we're going to stage patients. It also tells us how we're going to get them to the operating room, and more importantly, how we engage the multidisciplinary team, whether we get oncology involved or our endocrinology colleagues involved. I just put this out here in terms of octiotride scans. Those are available, but those are rarely helpful in lung neuroendocrine tumors. We reviewed our series of the last 44 teotride scans that we did in patients that presented with typical and atypical carcinoids, and none of them were diagnostic, so 0 of 44. Either they were negative or non-diagnostic. So lung, pulmonary neuroendocrine tumors, we stage and work up a little differently. And when we go back to that graph, and even when you look at the NCCN guidelines, they've changed a little bit in terms of what's included in working up a patient. And in patients to moderate to high grade, what we like to use now is a PET scan. And a PET scan is a little different than a CT scan. What it does is basically injects the patient with, for lack of a better description, radioactive sugar water. And sugar is taken up by metabolically active cells differently than regular cells, so they kind of shine on a background of something that isn't very well lit up. And all these cells that are very metabolically active will then be compared to the primary tumor. And if the primary tumor lights up, then it's a diagnostic scan. And those are predictive in about 80 to 85% of patients that have moderate to high grade histology. So it's much, 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 much more helpful. And so we rely on PET scans, and octiotride scans we rarely use, usually just in the workup of patients with metastatic disease. So the carcinoid syndromes, we've heard a lot about that today. Cushing syndrome in patients with MEN1 or MEN2. Again, very common discussions with patients with neuroendocrine tumor, but that's actually uncommon in patients who present with pulmonary carcinoid. So carcinoid syndrome, the actual patients who are syndromic with pulmonary disease is usually 1 to 2%. However, if they show up with metastatic disease, it's about 80%. And so in syndromic patients, if they truly have a biopsy that's suggestive of a low-grade neuroendocrine tumor and they are syndromic, you have to start thinking, do these patients actually have metastatic disease? And we work those up very differently and very aggressively. Cushing's is rare. Octiotride infusions for the surgery, all those things that you hear about in surgery for the belly, we rarely do. In fact, we haven't in many years. For MEN workup, just remember it's not that patients that have pulmonary carcinoids can have MEN. It's usually patients with MEN. So 5% of MEN1 patients will have also pulmonary carcinoid. So it's the patient that presents with a pulmonary carcinoid may very well actually have an MEN manifestation, but it's really not because of the pulmonary carcinoid. It's part of the MEN1 presentation. And so the panel of blood work and 24-hour urine collections is very uncommonly used in the workup of a pulmonary neuroendocrine patients, again, only if they're syndromic. And these are the European guidelines that I'm putting up here, and you can tell that they've changed the wording. It's only if clinically warranted. It used to say in all patients, and including the American guidelines, you say all patients, but the wording has changed now because the yield and the capture rate is so low that we only do it for patients that are symptomatic. The one thing that's different is a 2D echocardiogram, and that's because of the carcinoid heart syndrome. So in patients who have pulmonary carcinoids, we see a little bit more carcinoid heart, which means valvular problems or problems with the valve, and so we tend to get 2D echocardiograms of patients after they've had surgery just to see whether or not their valves have been affected. So that's sort of a brief overview. I'm going to go through some cases, just like you saw before, and just to highlight some examples of what we could encounter when it comes to surgery. This patient actually is not a carcinoid patient. He presented, in fact, as a lung cancer patient, and that little white mark, I don't have a pointer. Is there a pointer here? No. So anyway, there's a mark that's in the lung that actually was a lung cancer. So this patient went on to have surgery and a standard lung cancer surgery. But in fact, what happened, I don't know if that projects very well, but you can see that the patient had carcinoid tumorlets, multiple carcinoid tumorlets throughout the specimen. And this highlights two things. Number one, you have to have a center that is prepared to do the pathology that it's required not only to look at lung cancer, but to recognize other things that might be incidental findings. And we're fortunate to have excellent pathologists, pulmonary pathologists at our hospital at Sunnybrook Health Science Center. So David Huang and the group here found that these were tumorlets that could represent either metastatic disease or something that we see not too uncommonly in about 5% of patients that have lung cancer surgery, that these things could be representing of diffuse idiopathic neuroendocrine cell hyperplasia, which is basically something that predisposes a patient to later developing carcinoid. So this patient's lung cancer, although we would only monitor this patient for about 5 years, because of this patient's going to be on our radar for 10 to 15 years. And so that's very important to recognize as opposed to dismissing these patients. So that's a good example of concentrating this type of work in centers that have very good pathology departments. This is probably the most common that we see. So this is a patient, which was the x-ray that I showed at the beginning, has an isolated lung nodule, gets a biopsy, and this ends up being a typical carcinoid. And so surgery, just like you heard in our previous talk, is really dependent on a couple of things: the size of the tumor, where the tumor is, most importantly what it's stuck to, and what lymph nodes are involved. And the lymph nodes involved don't necessarily change the surgery, but change the prognosis. But in the chest, what this tumor is stuck to can sometimes change how we approach things. So for example, if it's attached to the spine or to a vein like the supravena cava or the lining of the heart, those are things that we can deal with. But if it's invading other structures like the aorta or the spine or the spinal column, those are a little bit more difficult and require either another surgeon or a surgery team, or sometimes we simply can't remove it. And that's where the bigger the tumor and the more advanced the nodal disease, those we tend to approach differently from a surgery perspective. We usually involve our chemotherapy and our radiation colleagues. One mention of biopsy, also very important to have interventional radiologists that are very comfortable doing core biopsies and not fine needle aspirates. So a lot of centers that may not be comfortable with biopsying the lung or other organs for that matter take only just a couple of cells, and that's not enough. You have to actually get chunks of the tumor so that you can have proper diagnosis. And when it comes to those endobronchial tumors, I'll talk a little bit about that. You don't want to biopsy those. You want to remove those as much as you can. And so that's very important. And when you have that diagnosis, then you go on to surgery. But one thing that's really important is that you treat these just like you would treat lung cancer. So we don't do things like wedges or just remove the tumor. And if anyone has that suggestion for you, you should really seek a second opinion. These should be treated like a lung cancer, which means an anatomic resection. So we take out a lobe, or we take out the whole lung if needed, or in the right patient, we do lung-sparing surgery. We just take out segments of the windpipe. But we should never just wedge them out. For example, that... I'm Italian, so I use my hand a lot. So the CT scan that you saw could have easily been wedged, 15-minute operation, 1-day hospitalization, but it would have been the wrong operation. That patient needed and got a lobectomy, and that's what you should have. And nowadays, you can look online. It's very readily available. CTSNet has wonderful videos, some of which are ours, that highlight minimally invasive thoracic surgery and lung resection and can show you that these can be done very safely. That's a picture of a patient on postoperative day 10 coming to the office, and you can usually get the procedure done with 3, sometimes 4 small incisions. Most patients are home within 3 days. Functional capacity of patients is almost back to baseline within about 3 to 4 months. So safely, but it is the right thing to do, is to be more aggressive with that surgery. This is that young woman that presented. So she came. I don't have a CT scan for her because we weren't able to do so because of her pregnancy. She went to have endoscopy done, and the proper thing to do here is not to biopsy that, is to remove it, because we know it's going to be a carcinoid, but we want to get as much of that tissue so that it can then tailor what we're going to do afterwards. This is basically right at the takeoff of the right lung, which means if the person isn't comfortable dealing with this type of surgery, the whole right lung would be removed in a 25-year-old woman. That's not the right thing to do. This person should have a segmental airway resection, and that should really be done by people who are experienced. I didn't realize how creepy it was, but you can see my face in the reflection of the camera there. But that's just to basically say that it really should be done in an operating room by people who are comfortable to do airway endoscopic procedures and not really as an outpatient in a bronchoscopy suite. And then this is another case, and this highlights the other type of small neuroendocrine tumors. And so this is a patient that has a biopsy and winds up having a large cell neuroendocrine carcinoma. And traditionally, these are patients that we would never offer surgery, but in fact, that's changing. And so I think there still is a very good role for surgery in patients with very focal disease, just like you heard in the last talk. If patients have only one spot, it hasn't spread, surgery is very effective for that. If there are nodes involved or if it's spread, then surgery is not very effective. And so for these patients, we treat a little differently. They get a PET scan, and if there's only one spot, no matter what the PET scan shows, they should always, and these patients always have the lymph nodes biopsied, and so that's called a mediastinoscopy, where we actually remove some of the lymph nodes behind the breastbone, and that's this person's pathology, and they were all negative, and then that gives us the green light to go ahead with surgery. And so that's the final pathology, which shows large cell neuroendocrine features, and you can see from the terminology it has quite a bit of the more aggressive type of features, but what's most important, treat it like you would any other cancer. You take out all the lymph nodes, and none of the lymph nodes were involved. This patient will still wind up seeing a medical oncologist and will be offered adjuvant chemotherapy. So there still is a role for surgery in small cell cancer or patients with higher grade neuroendocrine tumors, and should not be easily dismissed as not being having surgical disease, because that's not true. A very quick note about metastatic disease. We do sometimes see that, and I think, again, there is a role for patients who have metastatic disease, whether it be metastatic pulmonary neuroendocrine tumor or metastatic neuroendocrine tumors to the lung. Those we treat a little differently, but for the principle of today's talk, those are still not necessarily patients that should be dismissed. They should still be considered for surgery. A patient like this, for example, even though they have 3 or 4 spots, they're all in the same anatomic segment, which means we could still do the surgery sparing very little lung, even though they have 4 spots. Well, 4 spots in the right spot is actually something that can be operated on. And so these patients tend to have a little bit more of the issues that we were talking about before, like being syndromic, and so those are the patients that usually are dealt with in a multidisciplinary way. Unlike the previous cases, in these patients, a segment is acceptable, because what we're trying to do is trying to remove the metastatic focus, not prevent other metastatic foci. However, in this case, we wouldn't really offer patients removal of the entire lung, because that burns bridges for future therapy options in patients who we already know have metastatic disease. So that's a no-no when it comes to these types of patients. And I guess the last thing when it comes to metastatic disease, we have to be very careful. And although when patients present with primary disease, we hurry up and rush to get to the operating room, when patients have metastatic disease, we tend to be a bit slower. Why? Well, because when we see on the CT scan and what we see in the operating room are very different. This is not a neuroendocrine patient. This is actually a metastatic colorectal patient. But this patient wound up having 7 spots that we thought of in the CT scan and in preoperative evaluation. And it was discussed in our multidisciplinary case conference. Went to the operating room, but we found 21. And so that's the problem, is when you have a small little spot, that's what we see. But when we go to the operating room, we find more. And so that's why we tend to wait to see what actually manifests, to see if these are actually patients that are suitable. I think you heard that it's the biology that trumps everything else, and that's very, very true. So these behave differently, then we have to treat them differently. And then one last thing is surveillance. And so we monitor patients with cancers for a particular point of time. There really is no consensus. There are no guidelines. The only guideline basically says that you should surveil your patients. So typically with low or moderate risk patients, moderate risk neuroendocrine tumors, we follow those patients longer than in patients with higher grade tumors. And the reason is that they could manifest metastatic or recurrent disease much later. So the typical recommendation is 10 years and 5 years for the higher grade. However, when we recently surveyed Canadian surgeons, the range is actually very variable, between 3 months of surveillance, which is unacceptable for anything, to 10 years. And really we're trying to advocate longer surveillance periods for patients with lower grade tumors. So basically, in summary, I would agree with the statement that pulmonary neuroendocrine tumors are not rare, they're uncommon, and we should always be thoughtful when it comes to working up a patient that has a lung nodule. Careful staging and workup of the surgical patient for any surgery is very important, involving the multidisciplinary team when is necessary. Early stage patients have excellent surgical outcomes and should always be considered for surgery first, involving the multidisciplinary team, like I mentioned, and really for all of you who are undergoing this, at least from a lung perspective, you should be offered long-term surveillance. Thank you.